Dr. Prince Adotama is a board certified dermatologist and assistant professor at the Ronald O. Perelman Department of Dermatology at New York University, Grossman School of Medicine. He attended medical school at the University of Texas Southwestern, and he completed his dermatology residency right here at OU. He then went on to complete a complex dermatology fellowship at NYU, and he is a co-founder of the Skin of Color section at New York University. And he is going to talk to us today about scarring alopecias in Skin of Color. And so we are just so happy that you are coming to us from New York and to your alma mater, and we appreciate you delivering this today. Dr. Adotama.
Hello, thank you for that lovely introduction. I'm great to be home virtually at OU and be able to speak about something I really care about and I really love, treating patients with this condition in clinic and teaching residents and teaching the general population about. So let me share the screen. 1 second. Can you guys all see that? All right, so let's get started. I'm going to minimize the top screen. Okay, here we go. So what's new in scarring alopecia is a topic. We have a lot to discuss. I'm going to go right into it, okay? So as far as disclosures, these are my disclosures here. I will be discussing experimental or off-label drugs, devices, and/or therapies that have not been approved by the FDA. Some of our professional practice gaps, many healthcare providers, and really quick, I see that people are waiting to enter the room. I'm not responsible for that, right? All right, perfect. So professional practice gaps. Many healthcare providers may not recognize the signs and symptoms of scarring alopecia and skin of color, and how to treat them. Additionally, it's important to understand how certain hair care practices may contribute to scarring alopecia. So upon completing this session, participants will improve their competence and performance by being able to, 1, discuss the clinical appearance and symptoms of scarring alopecia in skin of color patients, 2, discuss the types of scarring alopecia in skin of color patients, and 3, review treatments for scarring alopecia in skin of color patients. So let's focus on hair biology. So when we look at the hair shaft and how it looks in Asian patients, it's typically more round to slightly oval shaped. In Caucasian patients, it's much more oval shaped. And in Afro-American patients, it's much more elliptical. And this leads to more curlier appearance of the hair, more tightly coiled hair. Another thing that's interesting about African Americans is that they have fewer elastic fibers. So elastic fibers kind of anchor our hair to our scalp. And African Americans or people of African descent have fewer elastic fibers anchoring their hair. So that's why often it's a lot easier for people of African descent to lose their edges, so to speak, because it's so much easier to tear that hair out. It's not as anchored as well. African hair appears to contain fewer lipids than Caucasian hair, leading to be more susceptible to ultraviolet damage. And sebum is something that travels down everyone's hair, right? And it helps to coat the hair and add moisture. But sebum, due to the curly texture of the African American hair and how coily it is, sebum does not travel down as easily on our hair. So therefore, our hair is not coated as much and our hair is more prone to dryness. And inherently, there's reduced tensile strength and less moisture in African hair compared to Caucasian hair. So a lot of different inherent factors that differentiate African hair compared to white hair. So for scarring alopecia is a form of potentially irreversible alopecia. Basically, the hair is scarred down and the follicles are scarred down. And for Black patients, alopecia is often scarring. It's much more often scarring than any other type of alopecia. CCCA is the most common form of scarring alopecia. CCCA stands for central, which means center of the crown, centrifugal, which means outwardly spreading, cicatricial, which means scarring, and alopecia, which is just another word for hair loss. So you have central, outwardly spreading, scarring form of hair loss. The prevalence is estimated anywhere from 2.7 to 5.6 among women of African ancestry, but there are some cases of African men having this condition as well. CCCA typically presents with decreased hair density. 1 second. All right. Sorry, I see something in the chat. 1 second. Okay. How do I go back? Okay, here we go. CCA typically presents with decreased hair density along the vertex of the scalp, but presentations may vary, and hair loss, like I said, may be irreversible. So there's different staging of CCCA. So there's 6 stages, 0 being normal hair, and there's 5 stages, right? 1 through 2 are considered early hair loss patterns. Stages 3 through 5 are considered probable CCA, much more late stage CCCA as well. And so A stands for more frontal accentuation, while B is more vertex accentuation, where the hair loss is more so on the vertex of the scalp. All right, and so we're learning more and more about CCCA, right? In the past, it used to be called hot comb alopecia. We're learning more and more that CCCA is not necessarily something that we caused ourselves, right? I think in the past, there was a lot of shame with CCCA because the idea was that you're relaxing, you're using hot combs, you're you, right? And so we're really trying to learn more and more about what's really the cause and etiology of CCCA. And it may not necessarily be may not be totally due to our own practices. This is a study that was published in New England Journal of Medicine where they actually identified a gene mutation. And so they found a gene called PADI3. PADI3 is found in the epidermis and in the hair follicles, and it's responsible for normal hair shaft formation, and it helps with differentiation of the epidermis. And so they found a mutation in a highly conserved residue of PADI3 gene. And this missense mutation actually leads to protein misfolding. In fact, PIDI3 is also found in other conditions like uncomfortable hair syndrome. But in this condition, it affects a certain residue. And so and as we know, CCCA, when it does run in families, is typically autosomal dominant with incomplete penetrance. And so the idea is that it's really multifactorial. So you have a genetic susceptibility, you may have it running in your family, so you may have this gene. About a third of patients potentially may have this gene. And then there are potentially inherent hair differences, as I mentioned earlier, like we have less elastic fibers, so our hair is more prone to traction and to damage. And then hair grooming practices, while it may not be causative, can contribute to hair damage, right? So I think it's a combination of things that lead to the presentation of CCCA that we see today: genetics, inherent hair differences, and hair grooming practices. And we're also learning more and more about CCCA because we know this is a scarring process, right? It's potentially an irreversible scarring process. So let's see. This is Dr. Agu's group at Johns Hopkins actually did a study where they wanted to find out what genes were preferentially expressed in CCCA patients. So here we see a total of 5 patients with biopsy-proven CCCA were recruited. And they did 2 scalp biopsies in all these patients, one from the CCCA-involved area on the vertex scalp, and one from the unaffected occipital scalp. And they did microarray analysis was performed to determine differential gene expression. What they found was very interesting. So this is a very busy slide, but I kind of want to break this down for you. So in the center is kind of no change, and below is less than 2 standard deviations below, and red is greater than 2 standard deviations in elevation, so an increase of greater than 2 standard deviations. And so the genes that were highly expressed, greater than 2 standard deviations, were genes that were found in more fibrosing disorders. So there was increased matrix metalloproteinases, increased collagen, increased collagen 1, collagen 5, platelet-derived growth factor as well. Matrix metalloproteinases specifically have been elevated in things such as idiopathic pulmonary fibrosis, hepatic fibrosis, right? And so we learned that this condition, while we always think of it as inflammatory, there's really a strongly fibrosing and scarring process, right? That was mainly the genes that were found to be elevated, fibrosing and less likely inflammatory. And this kind of checks out what we've been seeing in the past, right? This was a study that was done by Dr. Agu's group as well in 2018 that found a correlation between CCCA and fibroids. Uterine myoma is the other term for fibroids. And we know fibroids is very common in Black women, but when they controlled for age, race, and sex, they still found a higher occurrence of fibroids in the CCCA group, right? And so now I ask them my questionnaire for all my patients who have CCCA, do you have fibroids? And more often than not, fibroids is there. And fibroids is also a scarring process, right? So what we're learning is that inflammation, while initially maybe the inciting event that leads to fibrosis, the fibrosis tends to continue independent of sustained inflammation. Because when we do the genetic microarray analysis, inflammatory cytokines are not necessarily elevated. It's mainly the fibrosing genes are elevated, right? So inflammation occurs really early in the process. And antifibrotic therapies may play a role in the treatment of CCCA. Because when you think about it, there's increased matrix metalloproteinases, right? That's found in things like idiopathic pulmonary fibrosis and hepatic fibrosis. But things like doxycycline actually can decrease matrix metalloproteinases too. Pentoxifylline potentially can decrease these things. So there's more treatments that we can kind of use, hopefully in the future, that can target some of these elevations. The study also looked at lipid metabolism genes, and they found that lipid metabolism genes were downregulated in these patients. So lipids actually play a bigger role than we know in follicle homeostasis, and they may be a part of the family of the sterile coenzyme A desaturase family, which plays a role in sebaceous glands. And as you know, sebaceous glands with CCCA, the sebaceous glands are often targeted. They can be destroyed. You can have fibrosis around the hair follicles. So lipids may be the new frontier of treatments down the line. So a lot of exciting options in the future for CCCA. All right, how about hair breakage? So CCCA, we talked about the 5 different stages. Stage 1 through 2 is more early, stage 3 through 5 is more late stage and more chronic scarring stage. And once it's that stage, is really difficult to treat. So really one of our goals when we're treating patients with CCCA is to be able to diagnose this condition really early, right? Because as you know, it's potentially irreversible. So we can catch them early enough that we can prevent it from getting any worse, right? So Dr. Callender's group actually found that hair breakage was a potentially early sign for CCCA. And so what she did, she had a case series of 9 patients, and she noticed that these 9 patients all had hair breakage. And it wasn't necessarily significant, bald patches, but there was hair breakage there in the well-demarcated area of the vertex. Some patients had normal density, some patients had decreased hair density, but really minimal to no clinical evidence of scarring, right? So hair breakage could be an early sign. And what they noticed is that these patients also had pruritus in 78% of these patients and scalp tenderness. I didn't mention this earlier, but CCCA is often symptomatic. So especially when it's in the early stage, it can be itchy, it can be tender, it can be painful. And so when you have a patient with itchiness, tenderness, and they're having hair breakage at the vertex scalp, you want to kind of be thinking about CCCA, especially in the right patient, the right demographic. So early CCA should be considered in a differential diagnosis for women of African descent, right? And when they did biopsies of these patients, all of them showed signs that were supportive of a diagnosis of CCCA. So when you're seeing this patient and you're not 100% sure and they're having these features, a biopsy is a great option. Do not be afraid to biopsy your patients because you can save them a lot of pain and suffering in the future that this hair loss progresses down the line, right? So I am very pro biopsy, even in the early stages. All right, so the differential diagnosis of hair breakage. So when you have hair breakage, right, CCCA is a possibility, but there's a lot of different things that can cause hair breakage, right? Certain relaxers, if you leave the relaxer on too long, that can be damaging. Certain hair dyes can be irritating to the skin. Certain heat styles, such as hot combs, blow dryers, and high heat, sometimes that can be damaging. As we know with chemical relaxers, they can break down those disulfide bonds, and then heat can actually break down the hydrogen bonds. So it's really important that we recognize that other things can cause hair breakage, right? So don't necessarily jump to CCCA. Definitely want to do a full history and figure out what's been going on with them. And so what you want to know about this is that if you have a patient with just hair breakage and it's due to one of these other things, then you may not need to do a biopsy. You just need to focus on treating that brittle hair, right? And so there's a lot of different treatments that we can do. A lot of it's just tender loving care, TLC, right? We recommend using protein treatments. There are a lot of protein treatments out there. Olaplex is an example of a protein treatment you can try, Olaplex 3 specifically. Apogee also helps to improve protein and help to build the strength of those hairs if they're really brittle. So just things to keep in mind. All right, so diagnosis. I really love this study that Dr. Candace Heath made. And this basically was kind of an article, a viewpoint article on an approach to examining tightly coiled hair among patients with hair loss and race-supported patient-physician interactions. So we know that patients, especially dermatology patients, typically like race concordant physicians, meaning that Black patients typically like to be treated by Black physicians with the idea that they may have shared experiences, shared commonalities, and they may understand their hair better, right? And so this was a guide that Dr. Heath made for race discordant physicians. So when you have a patient that may be Black and a physician that may be white, some tips and tricks that may help help to improve that patient-doctor relationship. And so I think this is something that you guys should all look on your own. I think it's a great kind of table. But I learned tricks myself, right? So oftentimes you do a hair exam. If you're going to do a hair exam and you're standing up and you're looking through the hair, that's not the time to be saying, how often do you wash your hair, right? That's not the right time to do that. You want to do that while you're sitting down, ask all these questions, then go up, and then you can even bring a family member there in the room to accompany you as you examine the hair, right? Is there certain context clues and tips and tricks that can kind of help you to foster a really good relationship, especially when you're in a race discordant relationship? All right, and so here, now we want to talk about dermoscopy. Dermatoscopes are great tools that we use, and I use it every single day, multiple times a day in clinic. When we use it on the skin, we call it dermoscopy. When we use it on the hair, technically it's called trichoscopy, but either way, dermoscopy is what I like to do. And there's been a lot of studies on how dermoscopy can be used for scarring alopecias. One second. So one thing you can see is a honeycomb pigmented network, and that's found in about 96% of patients. Honeycomb pigmented network is also found in Black patients in general, so it's not necessarily specific, but you can see it. I think something that's a little bit more specific would be the peripilar white-gray halos, and I'll show you a photo of this shortly. But this is where around the hair follicle, you see these kind of a halo of gray or white, right? And usually it can involve around single hairs, or even more commonly, it can surround a group of 2 or 3 hairs. And this can be found in both early and late stages of CCCA. So this is very specific. It's something I always look for in my patients when I'm considering doing a biopsy or unsure of the diagnosis. Other things you may see are pinpoint white dots or white patches. So what's important is honeycomb pigment network is normal, right? And white dots typically can be normal as well. But if you have a lot of white dots, or you have white dots that are turning into white patches, and they're actually disrupting and interrupting the honeycomb pattern, that's uncommon. And that's more specific to CCCA or sparring alopecia. And you may also see erythema, scale. This is not specific to CCCA, but you may see this but these features are signs of active inflammation and suggest that you want to treat quickly. And when you're looking at the vertex of the scalp, where usually the action is mainly there, if you're unsure, you can always look at the occipital scalp, an uninvolved occipital scalp to kind of compare, right? Because you're seeing honeycomb pattern everywhere. If you see it on the occipital scalp, that may help you to say, okay, this is a normal finding. But if you're seeing more white dots in the vertex versus the occipital scalp, that kind of helps you, right? So I like to use the vertex scalp that's involved with CCCA and compare it to the occipital scalp in order for me to make a better diagnosis. All right, and so this is an example of a patient of mine with CCCA. As you can see here, there's some increased distance between hair follicles, quite a bit of distance between hair follicles. There's a honeycomb pattern, this kind of brown, kind of spider-like network that's kind of interrupted by these white dots and some bigger white patches. And then you can see these peripilar white-gray halos, right? Surrounding not just 1, but 2 hairs, right? Here you have a little bit here, you have a little bit here, right? So these are some features a little bit more specific to CCCA. And this also can guide you on where to biopsy. And sometimes CCCA can extend even beyond the biopsy, right? So this study, they looked at patients with CCCA, with diagnosed CCCA, and they actually looked beyond the scalp. They looked further out. They looked maybe on the right parietal, looked in the occipital scalp. Areas are very far. And sometimes when they looked at dermoscopy, they actually found features of CCCA even deep there. So this suggests that even sometimes when you think the CCCA is only right here, you might want to look around even further around in the margin because you may have CCCA in other places, right? And that CCCA could be spreading. So it's really important to consider treating a wider area and using your dermatoscope to help you so you can help to define the true extent of disease involvement. How about treatment? So this is going to be a slide that we're going to spend a little bit of time on, right? Ooh, I don't like this. Okay, perfect. So a slide we're going to spend a little different time on, all right? So the first thing, I'm going to start here. You want to avoid certain hairstyle practices that you think could be contributing to your hair loss, right? So when I say this, don't want people to tell patients of color, hey, you can't relax, you can't use heat, you can't do any of this, you can't. That's not helpful. That's very defeating and it's very difficult for the patients. But you do want to be able to tell them, hey, if your scalp is very inflamed, it's very itchy and painful, maybe take a break from relaxers or extend it less frequently, or use less heat at this time, right? So you definitely want to talk to them about certain hairstyle practices that can be contributing to it, especially when it's very inflamed. As far as treatments, we really recommend is high potency topical steroids. So something like clobetasol or halobetazol, a type 1 high potency steroid. And you can use that daily for the first 4 to 6 weeks, sometimes 4 to 8 weeks. And then after that, you can use it 3 times a week for maintenance. We also like to inject steroids. The hair follicles are deep down, so we like to inject, and I like to inject anywhere from 5 to 10 mg per milliliter. And I inject every 4 to 6 weeks, and while they're still having inflammation. So inflammation can be erythema, scale that you're seeing on the scalp, or inflammation can be symptoms. I'm having a lot of pain, a lot of itch on a vertex scalp. This suggests that your scalp is very inflamed and you need some topical steroids and ILK, intralesional Kenalog. Other things you can do when it's inflamed is oral doxycycline. Oral doxycycline has been shown time and time again to be very effective at controlling inflammation, right? Especially when a patient has very broad involvement, right? It's not just the vertex, it's involving the frontal scalp, it's very involved. Oftentimes a pill is great because you're treating the entire area. It's more systemic treatment there, right? So usually I recommend treating anywhere from 3 to 6 months, depending on the activity level. I also like topical minoxidil or oral minoxidil. Minoxidil helps the hair grow. So we want to control the inflammation with these 3 things. We also want to promote hair growth. So you want to control inflammation and promote hair growth. And topical and oral minoxidil is a great option for patients. Oral minoxidil is becoming more and more popular for patients. And it's very effective in CCCA patients as well. And there's some thoughts that minoxidil may have some anti-scarring properties as well. So it's beneficial in that way as well. If they have any sebderm or seborrheic dermatitis coexisting, you want to treat that. If their inflammatory phase of CCCA is still active despite all these treatments, then you can consider things like hydroxychloroquine. There's some evidence that it may be beneficial for an inflammatory CCCA that's just not responding to other treatment options. We're going to talk about metformin in a little bit, so I'm going to hold off on that. And then once a patient is doing well, say this patient has been clear for a year or 2, and they're not having any additional worsening of their disease is quiescent, then you can consider a hair transplant. Hair transplants should not occur until at least a year. Some people will even say 2 years of quiescence. Once it's been a year of no involvement, no activity, no pain, no itch, the treatment is well, you're starting to grow a little bit of hair, this is the time when you can consider a hair transplant. The fear of doing a hair transplant too early is that you transplant the hair, which is very expensive. The procedure is very expensive. You transplant that hair and that inflammation then destroys that new hair. So you want to definitely discourage patients from doing hair transplants too early. And oftentimes patients come to me, they've had CCCA for a while and they're like, you know what, I just want a hair transplant. And I see a lot of activity. So I really have to caution you guys about really talking to your patients about really waiting and make sure we treat the condition first before we head to hair transplant. And this is a study that Dr. Agu did as well, looking at topical metformin. And she found that it was useful for recalcitrant CCCA. And I want to caution people because metformin is a new treatment and many people are very excited about metformin and they're using it a lot, but it's really meant for patients who are in the scarring phase of CCCA. So it was in a microarray study that was done previously, it was found to have this gene, PARCA-A2, that encodes for protein kinase. And this was found to be underexpressed in about a third of patients with CCCA. And this reduced activity has been implicated in hepatic fibrosis and IPF as well. And so in mouse models, they found that metformin helps to reverse and accelerate the resolution of the fibrotic process, right? So metformin is really treating the fibrosing aspect of it, right? So this is a patient that Dr. Agu had treated, who I believe had been treating her condition for over 5 years. He had been on multiple therapies, had at least 8 or 9 injections of steroids. She had been through the ringer as far as treatment, right? So now she was really focused on the scarring phase of CCCA. And so what they did is they gave topical metformin, and 6 months later, she had a really good improvement, right? So just keep in mind that you can use a metformin, but just know when to use it. It's more for the later stages of the CCCA. And JAK inhibitors are the new game, right? JAK inhibitors have been approved over the last 2 years. JAK inhibitors work really well for a lot of conditions. And so this study was done by Susan Taylor and her group. And what they did was they looked at 6 patients with CCCA, and they matched them with 6 age-matched patients with female pattern hair loss. And as you can see here, these are the CCCA patients, these are the AGA patients. And as you can see, the JAK-STAT nuclear staining was more positive in the perifollicular lymphocytes and along the follicular epithelium as well, but that was not found in the AGA group. So actually JAK staining was much more positive in our CCCA patients. So this kind of opens the door to the possibility that JAK-STAT inhibitors may potentially be used for the inflammatory phase of CCCA. In fact, there is some clinical trials currently ongoing at many institutions in the country. Well, I know Mount Sinai is doing it, but there are some ongoing clinical trials for JAK inhibitors for the treatment of CCCA. And hopefully we'll learn more and more about that. That may be a new treatment on the horizon. How about PRP? PRP, or platelet-rich plasma, is where you draw your own blood, spin it in a centrifuge, take out that top portion that's chock full of growth factors and proteins, and you inject that portion back into the scalp. And it works, and it's been shown to work for female pattern hair loss, for male pattern hair loss. But there's some evidence that it may work for inflammatory alopecias as well, like CCCA, scarring alopecias. Unfortunately, there's not a lot of data. There's really just one case report. I think there's a few more case reports coming out. There's not a lot of huge data supporting its use, and it's a very expensive process. But there is some data that supports the use of PRP and CCCA, but it's just not enough for me to routinely recommend it for my patients. And oftentimes you would use this more in the scarring phase of the CCCA. How about seborrheic dermatitis? We know sebderm is very common. It's one of the most common concurrent hair disorders in patients with CCCA. As I mentioned earlier, itch is very common in CCCA, and it can be a marker of disease activity and disease severity. Similar to CCCA, sebderm may also be associated with scalp itch, right? So they sometimes can kind of blur the lines together. So for that reason, if you have a patient that has sebderm and CCCA and they're complaining of a lot of severe itch, you almost need to treat that seborrheic dermatitis with either ketoconazole or cyclopirox, or even better, Head and Shoulders makes some, Head and Shoulders Royals has like this zinc type treatment that has argan oil and zinc, and it's a little bit easier on afro-textured hair. There's all these different options for treating seborrheic dermatitis that I want you guys to really consider. But the idea is sebderm needs to be treated as well, just because it's often concurrent and it can kind of blur the activity levels of CCCA. And then what they found was in this study was that this sebderm is inflammatory. So is it possible that sebderm could be an exacerbating etiology of CCCA? Could it be an inflammatory kind of marker that's actually irritating and causing progression of CCCA? So we really don't know yet. We're learning more and more about sebderm and its role in CCCA. However, the main take-home point is always consider treating coexisting sebderm with any way you can in order to improve outcomes. How about frontal fibrosing alopecia? So frontal fibrosing alopecia is an increasingly common form of scarring alopecia. It's been increasing like crazy over the last few decades. It predominantly impacts Caucasian women. This is one of my patients with frontal fibrosing alopecia. And what it causes is a symmetric band-like zone of progressive hair loss. So it just kind of progressively has your hairline receding, right? And it's scarring. So sometimes it's very difficult to get that hair growth back. It also can lead to hair loss of the eyebrows, of the eyelashes, and sometimes patients can have papules on the face as well. But we're starting to learn that more and more people of color and men are actually developing FFA as well. So it's not just specifically women like we once thought. But the exact etiology is still unsure. We're not really sure why it's happening more and more and more. And so many people are now recommending patch testing. So at NYU, with one of my colleagues, Dr. Losico, and Dr. Senna at Harvard, they did a study where they did patch testing on all the patients with a lot of patients with FFA. And what they found was that about 81% of the patients with FFA at least had a positive reaction to some type of patch testing. And and if you look to include LPP, about 76% of patients had some type of positive reaction to patch testing. The things that they found mostly were fragrance mix and linalool. Linalool is also a fragrance, so it's found in a lot of cosmetic products. And galates is basically a stabilizer. It's ubiquitous in a lot of cosmetics and cleansers and creams and moisturizers as well. And so what they found is when they did the patch testing and they removed these allergens, patients actually improved. There was less inflammation in the involved area. So this study actually advocated for patch testing and actually and they found that removing those allergens actually improved outcomes. Here was another review looking at FFA and personal care products. This was a systematic review that was just published earlier this year, really last month, and include 9 studies totaling 1,200 FFA patients and 1,400 controls. And they found significant positive associations for FFA and sunscreen. And sunscreen has been this kind of new thing that we're worried that may be contributing to FFA's rise in incidence over the past few decades. And they found an odds ratio of 3. They also found that facial moisturizers were more often associated with FFA with an odds ratio of 2. Basically, an odds ratio means they're 2 times more likely, patients with facial moisturizers are 2 times more likely to develop FFA than not. And then so when they did sub-analysis based on gender, they found that moisturizers still were positive in men, but not so in women. So basically, this study basically said that there was a potential environmental etiology in development FFA, which is something that we're starting to learn more and more, and we're cautioning our patients and recommending patch testing when we can. And so this was a kind of an editorial that was done by Dr. Lim and Henry Ford and Dr. McMichael. These are experts in hair loss and patch testing, and they wanted to find out, like, so why are we having why is sunscreen associated with FFA? And the dominant theory is that sunscreen may penetrate the follicular infundibulum. This may elicit some type of reaction, a lichenoid reaction, that leads to a breakdown of immune privilege and that leads to a development of this autoimmune disease process. Sunscreen could also potentially be an endocrine disruptor, and the endocrine disruptors kind of affect your hormonal system potentially and increase your risk. Theoretically, could potentially increase your risk for hormonal malignancies and things of that nature. Paraben is an example of an endocrine disruptor, and so a lot of companies are removing parabens from their products. Or is this just a coincidence? We're really not sure. There's still more studies that need to be done. However, I do think that it's reasonable to consider patch testing your patients for FFA at least, just to see if there's any coexisting allergens. And then how about FFA in Black women? So this was a study that I did with Dr. Callender here at NYU, and we compared our patients to her patients. And we just looked at the differences, the clinical differences between white women and Black women with FFA. And so what we found was lichen planus pigmentosus was more commonly found in Black women. And lichen planus pigmentosus is basically a variant, it's a lichenoid inflammation, but leads to hyperpigmentation, usually on a face, sometimes on a neck, and it can be associated with FFA. And in our study, there was an odds ratio of 38. So it was a huge increased odds of developing LPP if you were Black. And 57% of the Black women had LPP versus 3% of the white women. And this was also found in another study. There was a previous study done that looked at it was a case series, and they found 7 Black women with LPP and FFA, and they first noticed it, and then we kind of followed up with our study, seeing that correlation. There's also a younger age of presentation. The Black women typically present with FFA a lot younger, at the average age of 53 versus 63. The Black woman had way more itch, 50% had itch compared to 5% of white women. But as far as other features, we did not see a significant difference in eyebrow loss, eyelash loss, or facial papill involvement. It was mainly LPP that we saw, which is a huge thing, itch, and younger age of presentation. And this is a patient of mine who I love. And so she has FFA biopsy proven, and she also has lichen planus pigmentosus. This photo is not great, but you can see some of this hyperpigmentation kind of on the bilateral cheeks, and we're trying to treat that as well. And so you'll find that your patients with Black women with FFA want you to address not only the FFA, but also the lichen planus pigmentosus, which are both very difficult to treat, but you definitely want to at least consider some options for that. How about standardized measurements? So Dr. Shapiro, who I work with here at NYU, is a big proponent of measurements and taking photos. And so what he likes to do for FFA specifically is to take 3 measurements, one from the mid-glabella to the frontal hairline, one from the right lateral canthus to the right temporal hairline, one from left lateral canthus to left temporal hairline. And the idea is to make measurements and take photos every single time. Because if, you may think, oh, it's looking good, but if you're not taking photos and taking measurements, you may realize a year may have passed and your hairline is receding and you're thinking things are going well, right? So it's really imperative that we're taking accurate measurements and photos at every single visit so we can assess progression, stabilization, or improvement. So this is something I do on all my patients. And this is a new condition called fibrosing alopecia in the pattern distribution. So what it is that you have patients that look like AGA, femoral pattern hair loss. Femoral pattern hair loss, for those who do not know, is basically frontal hair loss with widened hair parts on the frontal hairline, right? So you have widened hair parts with thinning on the frontal scalp. And so these patients actually don't have femoral pattern hair loss. They actually have fibrosing alopecia in a pattern distribution. So how can you tell, right? That looks like AGA, that looks like femoral pattern hair loss. These are some features that can help, right? So you see a patient with AGA, clear classic femoral pattern hair loss, you want to actually pull out your dermoscopy, do some trichoscopy, and look at it. If you do dermoscopy, you will see that they may have perifollicular scale, and perifollicular scale is more common in LPP. They may have decreased follicular ossia, so signs of scarring. They may have miniaturization as well. And then when you biopsy it, they have features of a scarring alopecia. They have perifollicular fibrosis. They have a lot of inflammation. So these are patients that look like AGA, but upon dermoscopy and biopsy, they're actually FFA. And that's crucial, right? Because the treatments are very different for a scarring alopecia and an AGA. So take-home points from this study is that fibrosing alopecia in a pattern distribution is a scarring form of alopecia with lichen inflammation, and it looks similar to AGA or femoral pattern hair loss. So you want to consider your diagnosis, you want to consider this diagnosis when your hair loss resembles AGA, but on dermoscopy or trichoscopy, you see signs and features of a scarring alopecia, or you see the patient's complaining of itch or pain or symptoms. This is when you should your index of suspicion should be high and you want to consider doing a biopsy. So I'm doing dermoscopy on everyone. If someone has classic AGA, I'm still pulling out my dermatoscope to making sure that they're not having a fibrosing alopecia in a pattern distribution, because the treatments are more so a combination of AGA, but also focusing on halting that progression and treating that inflammation. All right, so traction alopecia. So traction alopecia is where you kind of lose the edges. You're losing the hair, you're losing hair on the frontal hairline and the temporal hairline. Very common in people of color, particularly African-American women, and that's thought to be due to a host of different factors, but also due to decreased elastic fibers as well. So while initially it's non-scarring, prolonged tension can lead to a chronic scarring, irreversible form of alopecia. And clinicians may see a positive fringe sign, and I have a picture to show, which is a sensitive sign. So tight hairstyles can contribute to this, right? So tight braids, tight locks, ponytails, there are high ponytails, buns, certain weaves can all contribute to this, right? And so we're not saying you can't do this. We're just saying you have to be cautious of it, right? So if you're wearing a high ponytail and it's causing a lot of tension, not so good. If you're having locks and you're retwisting it every 4 weeks and you're constantly retwisting, that kind of increases your risk of tension, right? If your braids are if you're having micro braids or very tiny braids, that's a little bit more intention, right? If you're doing cornrows or anything like that, and it's vertical cornrows, that's really pulling vertically, that can increase tension, right? So if you're having a wig and you want to cornrow your hair underneath it, maybe cornrow horizontally as opposed to vertically. That way you're not putting so much tension. And it's a wig anyway, no one's seeing that. So just, try to find a way to put less tension on your hair as much as you can, especially if you already have traction alopecia. And if you're gonna use any type of traction-inducing hairstyle, definitely do it on your natural state. Do not do it on chemically relaxed hair. That will cause even more tension. So we recommend natural hair, looser hairstyles in certain ways. This is an example of a fringe sign where you have hair loss here on the edges with a lot of hair here. This is the fringe sign. This is very sensitive for diagnosing traction alopecia. And you can see here, this is not good. You can see how much tension, you have tinting of the skin. This is not good, right? This is causing tension. This is likely painful for the patient. Sometimes patients have pustules on this area as well. These are all signs that this is too tight. I know this hairstyle is intricate and lovely, but you gotta take that out, right? That's gonna lead to traction alopecia down the line. And traction alopecia, some clues that you can see on dermoscopy or trichoscopy is you may see these white concentric casts along the hair. So not necessarily along the follicle, but along the hair itself. So you can see these white concentric casts along the hair. And I often see this actually. So I'm not just doing dermoscopy on the scalp, I'm actually looking at the hair follicle, the hair itself. And this can be a sign of traction alopecia. And then for FFA, you may see some peripilar scale, but oftentimes FFA is only terminal hair. So you don't see any miniaturized hairs on the hairline. It's just terminal hairs, no vellus hairs whatsoever. These are all signs of FFA. It takes practice to get better at dermoscopy, but it really helps you when you're trying to diagnose hair loss and hair loss in people of color, especially. And this is a study done by Dr. McMichael looking at injections for traction alopecia, right? So the idea is we know traction is due to tension, but there is some idea that there may be some subclinical inflammation that may play a key role in the pathophysiology of early stages of traction alopecia. So she believes that injecting with steroids helps to control that inflammation. So this was a retrospective chart review of about 6 patients. All patients demonstrated visible, and all patients after injections actually showed improvement with intralesional canalog. So this is a patient at baseline, after 2 treatments, and after 1 year, after 3 treatments, right? And so as you can see here, you do injections really along this hairline. I believe she did canalog 5 and really great improvement. And just to keep in mind, I know it seems you're thinking like 1 year, keep in mind, our hair grows in 3-month cycles. So sometimes when I may be injecting every 4 to 6 weeks, but your hair needs time to grow, right? So sometimes patients, I'll see them on day 1 and I'll inject again on day 30. And they're like, my hair didn't grow. I'm like, if I shaved your head bald, it wouldn't grow that quickly. Your hair takes time. So you really want to give it some time, but injections really do help with that subclinical inflammation and help to improve hair growth in patients with traction alopecia. This was seen in this study, and this is also seen anecdotally in my clinic. So recommendations are 5 mg per milliliter. Sometimes I do 2.5 if there's some signs of atrophy in the area. And you can inject every 4 weeks. Some people do every 6 to 8 weeks, really depends on you. And you want to do up to 3 treatments if you can. Sometimes you may do more if things are not doing what they need. In addition, treatment for traction also involves Rogaine or topical minoxidil. Minoxidil has been shown it may have some anti-scarring properties, but also promotes hair growth. So these patients typically get minoxidil, topical or oral, and they get injections with intralesional canalog, and often topical steroids as well. And of course, you want to discuss minimizing any type of hairstyles that could potentially be worsening your disease process. All right, and now we want to talk about low-dose oral minoxidil. So oral minoxidil is kind of the new kid on the block. It's been around for decades, right? But I think more and more doctors are using it more frequently. And so oral minoxidil can be used to treat hair loss. Topical minoxidil works well, but there's evidence that oral minoxidil works even better, especially in AGA for topical minoxidil. But this is the first study looking at oral minoxidil for traction alopecia. So they retrospectively reviewed the records of patients with traction alopecia, age 12 and up, who have been treated with low-dose oral minoxidil for at least 6 months. Included 58 patients, only 6 were Black, I know, but this was Australia, all right? But 58 patients were done, and these patients, that they said in the study, a lot of them did high buns, and they did styles that they felt led to their traction alopecia. The mean starting and final doses were 0.75 milligrams and 2.5 milligrams respectively, which tracks, right? I typically start my patients at 1.25 milligrams, and I usually go up to 2.5 for women, up to 5 milligrams for men. And what they found, and that these patients were not patients who just started out of nowhere. These patients had a mean duration of 6 years of traction alopecia. So spontaneous regrowth was unlikely in this group of patients. So when they started low-dose oral minoxidil, they found a reduction in the mean score of 5.1 to 3.6. And the patients did really well in their traction alopecia, and they did really well, including those 6 Black patients. And so in my experience as well, I found oral minoxidil to be a very safe and effective management option for patients with really all forms of alopecia. I use it in female pattern hair loss. I use it in male pattern hair loss. I use it in CCCA. I use it in traction alopecia. Just keep in mind, this medication has its own side effects. If someone has a lot of cardiovascular risk factors, you probably would want to consider talking to their cardiologist or even consider not using this medication. There are risks of palpitations, lower extremity swelling. Patients also there's a risk of pericardial infusion. So things that you want to really consider for these patients, those risks are low, but it's possible. And the risk for hypertrichosis has been cited to be as high as 28% in some patients. So I've been yelled at by my patient one time because she was growing a lot of hair in other places. So keep in mind, this is not an option for everyone, but something to definitely consider. All right, and so in conclusion, the incidence of scarring alopecias like CCCA and FFA have increased rapidly over the past few decades. While the etiologies are not completely understood, we are learning more and more about their origins and their associations. A comprehensive history, clinical exam, dermoscopic or trichoscopic evaluation, and histopathological assessment may be necessary to make an accurate diagnosis, right? I'm not saying you always have to biopsy, but you need to really consider everything all together to make a diagnosis, right? Fibrosing alopecia and pattern distribution is a form of scarring alopecia, and you really often need all of these things to be able to make that diagnosis. Treatment of scarring alopecia is multimodal. It may require injections, it may require topicals, it may require pills. So there are a lot of different options that you may need to consider for your patients. So you want to have there's a lot of communication with your patient, and shared decision-making is really important in order to come to the right therapy. And a combination of therapies may be needed to improve clinical outcomes. All right, I think that is it. I think I finished on time, so I am ready for any questions.
Thank you, Dr. Adotama. That was wonderful. Great review of scarring alopecias and skin of color. We'll have our chat monitor ask some questions.
Would you like me to look at the question?
If not, we can go ahead and ask. There was one that was, what TCS vehicle would you recommend for the scalp if the patient is not washing the hair daily?
So I typically recommend ointments. I think ointments are pretty reasonable and protect your hair patients. And washing your hair daily is not going to happen, and it's not a recommendation for people of color. So washing hair daily is like, I don't expect anyone to wash their hair daily. That's extreme. That can actually be a little damaging, especially with shampoos. So I recommend washing your hair every week to every 2 weeks, but at least every 2 weeks if you can. And I recommend ointments. I think those are best for patients.
Excellent. I have another question. Go ahead.
I can unmute now. I apologize. The next question is, would you still feel like it's appropriate to use finasteride or spironolactone in FAPD, or not as much?
So I think what people don't realize is that oftentimes there's a lot of overlap with these conditions, right? So for example, CCCA is a hair loss that's common in Black women. But when they do biopsies, there's a study, I believe, that did biopsies, and about 60% of them had signs of miniaturization, suggesting that a lot of people also have AGA, right? So there's nothing wrong with, when controlling the inflammation with anti-inflammatories like Doxy and IOK, also recommending treatments to promote hair growth. So I like oral minoxidil, but I'm all for giving a little spironolactone finasteride as well, right? So at this point, treating with multiple modalities is really important, right? This idea that this is CCCA, this is the algorithm, this is the only thing, is not going to work, right? You want to treat different aspects. Same thing with men. Up to 80% of men will get AGA at some point, right? So if I'm treating FFA, they're likely having some AGA component as well. So you can really treat other aspects of their condition and improve it. And if you have a patient with really bad scarring alopecia or CCCA in a Black woman, improving the hair density around the hair actually can hide that hair anyway. So it's still beneficial to use other medications like finasteride and spironolactone to improve hair growth.
Awesome, thank you. And what strength of ILK are you using for injections for traction alopecia specifically?
So I use 5 mg per cc. Sometimes I use 2.5. I think for scarring alopecias in general, 5 is kind of the lowest I like to give. There was a study done by Dr. Jerry Shapiro that looked at alopecia areata, and it showed that 2.5 was fine. And I do agree that alopecia areata 2.5 is fine, but I think when I'm dealing with a scarring alopecia, I do prefer to use at least 5. Now I will not use 10 attraction, but I will use 5. And if I'm seeing any atrophy, I may go down to 2.5.
And then along those lines, do you have any tips on how to help prevent steroid-induced hypopigmentation when you're doing the ILK?
No. You just want to make sure that you're going to the right depth. You want to kind of go where the hair follicle is, like kind of that subcu dermis kind of area. But unfortunately, it's a condition, it's something that may happen, but oftentimes when you're treating hair loss, the hypopigmentation is not really the biggest concern for my patients. And there's no real tips for it. It's just something you have to caution your patients and let them know that this is a potential risk.
And what dose of doxy are you using for the fibrosing alopecia, the patterned?
So I use for really all alopecias that are scarring alopecias, I typically use 100 milligrams BID for the first 3 months. And then if they're still having inflammation after 3 months, I may go down to 20 BID, which is the antimicrobial dosing. The antimicrobial dosing has been shown to decrease matrix metalloproteinases. Antimicrobial dosing is very effective as well. The sub antimicrobial dosing is also effective at helping inflammation. So I'm okay with doing 100 BID for the first 3 months, then 20 BID for the latter 3 months. Or if someone really doesn't have much inflammation at all, and it's very minor, I might just start with 20 BID.
And then how do you usually go about counseling patients when you put them on oral minoxidil about the risks of hypertrichosis?
I say the risk is 28%. So the risk of topical minoxidil hypertrichosis is about 7%. The risk of oral minoxidil hypertrichosis is 28%, and it's everywhere. And in my experience, 28% sounds a little low. In my experience, it's like 50 or 60%. I just tell them all, like, you're gonna grow hair. It's gonna happen. Let's talk about it, right? I'm really a big fan of shared decision-making. In New York, where I work and where my patients are very young, everything is a discussion. I don't just say, we're gonna do oral minoxidil. I say, we could do oral minoxidil. What are your thoughts? There's a pretty high risk of hair hypertrichosis. What can we do about this? Are you okay with that option? We can consider laser hair removal. We can consider waxing. There are other options we can consider. But the idea that these conditions, these treatments don't have side effects, they all have side effects. It's just a conversation between you and the patient.
Thank you. Do you have you seen in your experience any significant differences clinically in Latinx patients with hair loss?
In my experience, no. In my experience, I've not seen any differences clinically. But hey, that just makes it just sort of anecdotally, I have no experience, but I don't see as many Latinx patients as I see Black patients. So I'm not the authority on that. But if you have a large Latinx population with hair loss, do the study. It's useful information, right? It's really useful to add that information to literature because it helps to guide everyone's treatment algorithms moving forward.
Absolutely. And also, have you seen anywhere in the literature that most of these treatments that we use for scarring alopecia can also be used for beard growth?
That's a big question. I feel like most of these treatments, yeah, I think that's a big question. Beard growth is a totally different topic, totally different situation, and a scarring alopecia and beard growth is not a scarring issue. So the answer would be no. I think with scarring alopecias, we're focusing on inflammatories, anti-inflammatories. With beard growth, we're focusing more so on just promoting hair growth. Sometimes we use microneedling for that, but that's a totally different topic.
We have another counseling question. So if you have patients that tend to deny traction because they have groomed the same way for many years before having any signs of alopecia, how do you go about approaching this issue?
I biopsy. You know, I feel like it's important to have buy-in from your patient. It never works to try to convince a patient that you have something and they don't. if you're convincing your patient that you have this diagnosis and they don't agree with you, they're not going to agree with you unless you give them some evidence for it, right? So you can show them dermoscopic features of scarring. So you can take photos of it on your dermatoscope and then take photos of that dermoscopic photo and show, hey, these are features of scarring. You can see decreased follicular ostia. You can see white concentric cast. You can do a biopsy and say, hey, the biopsy showed signs of scarring. Sometimes you need to give them more evidence in order to prove that. And working in New York, I had to give evidence to a lot of my patients. And honestly, it's important because oftentimes AGA can look like traction in Black patients. So they may be correct in some regards that sometimes it really is just AGA. AGA can present with temporal hair loss as well. So it may even help you to do a biopsy.
And then do you also like to use Dermasmooth or fluocinolone oil as well?
Yeah, I love the fluocinolone. I think fluocinolone is a great option for patients. Typically, when you have a scarring alopecia, though, you want to use the type 1 high potency steroid. But I think when you're going to the maintenance regimen, so say you used a type 1 high potency steroid for the first 4 to 8 weeks, and the inflammation is better, you don't see any erythema, you don't see any scale, the patient's not complaining of pain or itch, then you can kind of switch to a lesser potency steroid and use it less frequently.
And we often like to counsel that minoxidil is more of a lifelong treatment, especially for androgenetic alopecia. But do you ever consider stopping PO minoxidil once traction alopecia improves or reaches the goal of treatment?
Yeah, I do, because I think traction alopecia is not the same as AGA necessarily. For when I treat someone with AGA, I kind of frame it as like this is kind of a lifelong journey we're going on with this hair loss treatment. But with traction alopecia, we're kind of treating towards a goal. And if they're actually stopping their hair care practices that are causing some of that traction, then yeah, you can switch it. But I usually wouldn't stop it completely. I might just switch it to a topical minoxidil.
Awesome, thank you. And is there any role for tacrolimus?
For what? What condition are you referring to? So TCM therapy is something that Dr. Jerry Shapiro has created, and it works beautifully, and it's a great therapy for FFA and LPP. So I use it for FFA and LPP. I don't necessarily use it for CCCA.
And then another question about what the dose of minoxidil that you're using for the traction alopecia.
So I use the same dose for all hair loss disorders. I start at 1.25 for women and go up to 2.5. And for men, I start at 1.25 as well, and I'll go up to 5 if necessary. But keep in mind, the side effects of palpitations, of hypertrichosis, those side effects are real. And palpitations, I probably had a good 7 patients have palpitations. So it's not, it's not so easy that you should be giving it. You should be checking blood pressures at every visit. You should be making sure that they're not on any other antihypertensive. You should make sure they don't have a huge cardiovascular risk factors, right? Because there's this rare risk of pericardial infusion, right? So it never looks good when a dermatologist causes that, right? So they have a lot of cardiovascular risk factors. Maybe consider a different treatment.
And then do you have any tips on avoiding irritation or redness in patients that are using topical minoxidil?
So sometimes some variants are worse than others. Sometimes you can use a foam versus solution. Solution sometimes can be more irritating because of propylene glycol in it. So you can sometimes use a foam, which sometimes may not be as irritating. I believe there are some compounding pharmacies that can make minoxidil without propylene glycol as well. There are also some other brands that make minoxidil in the oil that you can find online on Amazon. So you just got to play around with it a little bit.
Awesome. Thank you so much. That was a great talk, Dr. Adotama. We really appreciate it.
Thank you. I'm glad to be here.
Excellent. Thank you so much. We had really enjoyed it, and we will have you back again. So thank you so much. And
Anytime.
stay around a little bit later here, in and out.